Good evening, friends, and a warm welcome to this edition of Med Talks. Now, diabetes is an ever evolving field. It's really dynamic. And to defeat diabetes, to be one step ahead of it always, we have to be even more dynamic, even more updated than the disease itself. That's why we bring to you today the latest recommendations from the ADA 2022. We have a huge armamentarium of anti diabetic drugs. We have traditional drugs, we have new ones, we have new ways of screening, diagnosing, and monitoring. We have new ways of delivering drugs. But sometimes we find it difficult to distinguish between diamond and coal. And many a times we are guilty of throwing away the baby with the bathwater. That is what has happened with respect to one diamond, one uncut diamond, which is pioglitazone. So today we'll focus on pioglitazone. We'll talk about updates on pioglitazone and how we can use it in the management of diabetes and in other conditions. Now, there is a parable in the Bible. The Bible, the Gospels are known for their parables, for words of wisdom, and there's a parable of the lamp. Now, the point is, if you have a lamp, where will you keep it? Will you keep it under your bed? Or will you keep it on the stand so that it can illuminate the entire house? Similarly, if you have knowledge, what will you do with it? Will you hide it in your pocket or will you share it with everyone, all peers, all friends, so that they can share that knowledge with their patients and contribute to well-being of the public? The answer is quite obvious. And to add strength to what we've just said, we have with us Dr. Bobby Matthew. Dr. Bobby Matthew is an endocrinologist. Warm welcome, Dr. Matthew.
Thank you, sir.
And it's great having you, Dr. Matthew. Would you like to tell us about your journey in endocrinology? What brought you to the field of diabetes management? What are the challenges you face? How have you evolved as a diabetologist, as an endocrinologist?
Okay, sir. Nothing. I finished my MBBS and MD in Kerala, Trivandrum Medical College. I did my DM endocrine from KEM in 2003 to 2006 and practicing ever since then in Kerala. And for the past 10 years, 15 days I work in UAE, Sharjah, and 15 days I work in Kerala like that. But totally practice oriented. But in between, we read just like a common medical practitioner who practice outside the medical college. Because not into research setting, but commonly we see patients on our own. But many times we see diabetes and but sometimes we see other case also. Diabetes becomes nowadays endocrinology is so vast in Kerala and all. In a district like Cochin itself, there are 50 to 55 DM endocrinologists. Such a small place, 50 to 55. So the competition is also there, but everyone has their own cases. Diabetes people may not refer to you, even though thyroid they may not refer, but pituitary, suspected Cushing, adrenal masses, Klinefelter syndrome, like that short stage, such things you get referred. And diabetes is invariably bread and butter. When I come to this country, UAE, I see 80% is diabetes and thyroid only because endocrine cases many times go to big hospitals where they get good insurance coverage and other things. But my passion for diabetes invariably is there. Diabetes, thyroid, andrology, I like testosterone and male pubertal endocrinology because studied in KEM. Nalnisha madam was more into pubertal endocrinology growth disorders. So like that, sir.
So that is the strength that Dr. Matthew brings to the table today. Uh, he is well grounded. You can see how humble he is, and he works both in India and abroad, and he is able to handle a wide spectrum of disorders. In this, Dr. Matthew, how does pioglitazone place? Would you like to share some slides with us? Would you like to
Yes, sir.
talk to us about the basic science, the clinical science, and actually how we can practice diabetology using this drug?
Yes, sir. Shall I start the presentation, sir?
Sure. Yeah, thank you.
Okay. Thank you, sir. Yeah. Hi, everyone. It's a talk on pioglitazone and the controversies and the newer strength of pioglitazone re-emergence. I'll be just touching and finishing in 25, 30 slides. Probably now it is, I'll be finishing in 40 minutes and discussion with Carl Russell. We know that 90% of diabetes that we see in our OPD is type 2 diabetes and 10% is type 1 diabetes. Both type 2 as well as type 1 diabetes is on a rise. Invariably, you open Harrison. Harrison tells you that 90% of type 2 diabetes people have a BMI more than 30, that is diabetes or metabolic syndrome. But Indian scenario, we know that 50% of the diabetic patients that we see in our OPD have a BMI between 23 to 30, And many times we see morbidly obese patient coming with a normal HbA1c, whereas patients having a thin moderate built phenotype of BMI 23 to 50, 23 to 25, having an HbA1c more than 10. So that is known as a thin obese Asian or Indian phenotype. An Asian or Indian may be looking thin externally, but he or she is obese internally. So to understand the thin obese Asian or Indian phenotype, think of a person like me, age 45 years, with abdominal obesity 95 centimeter. You take a US citizen with the same abdominal girth as that of me. Take a CT scan abdomen at L4, L5 level of me as well as a US citizen. Indian with the same abdominal girth is thought to have 3 to 5 times much higher visceral or intra-abdominal fat mass compared to the Western person. That is when we all used to study for MBBS, MD, we know there is subcutaneous fat that is behind our skin and visceral fat that is omental fat in and around our omentum. So Indian may be having the same abdominal gut compared to the Western population, but our visceral or intra-abdominal fat mass is 3 to 5 times higher compared to the Western population. That is what I say thin externally but obese internally phenotype. Because of the thin obese Indian phenotype, BMI cutoff for overweight for India is 23, whereas the BMI cutoff for overweight for Western subpopulation is 25. BMI cutoff for obesity for Indian subpopulation is 25, whereas the BMI cutoff for obesity for Western subpopulation is 30. So invariably, Indian is having a thin obese Indian phenotype. Why this is important? Because during our MD days or DM days, we used to have a classification of type 2 diabetes treatment where people used to say type 2 diabetes was divided into two, BMI more than 26 and less than 26. More than 26, always give metformin and sulfonylurea. Less than 26, you prefer sulfonylurea other than metformin. People used to think that you're obese, then only you have given metformin or a sensitizer. Now you know Indian is having a thin obese Asian Indian phenotype. If you label as a type 2 diabetes, you know that the basic physiology is insulin resistance with the predominant beta cell failure in the Indian subpopulation. And now coming to this concept, this is for basic doctors, MBBS doctors or MD doctors. At times, MBBS doctors come and ask, what is the importance of abdominal obesity? Why a male with a small pouch of abdomen is thought to have high chance of type 2 diabetes compared to a female having a large amount of fat in their thighs, breast, or buttocks? A guy comes with a small pouch of abdomen, his HbA1c is 8.5. His wife may be having massive amount of fat in her thighs, breast, or buttocks, but her HbA1c is 5.2. So fat wherever is fat, but it is the abdominal obesity which is the biggest risk factor for metabolic syndrome and type 2 diabetes. We know that abdominal obesity is divided into two components, subcutaneous fat behind our skin and visceral fat in and around our omentum. Next sentence, understand, visceral adipocyte is thought to be highly metabolically active. That is, triglyceride stored in the visceral adipocyte gets easily broken down to glycerol and free fatty acids. And these free fatty acids drain directly via water circulation to the liver, causing a fatty liver and hepatic insulin resistance. Roughly understand, subcutaneous fat, that's the fat behind our skin, drains to the peripheral capillaries. That's the visceral fat drains via water circulation to the liver, causing a fatty liver and hepatic insulin resistance. This explains why liposuction, which is a cosmetic surgery to reduce your body weight, never controls your HbA1c. There's a bariatric surgery, either a banding or a bypass, which reduces your visceral fat, controls your HbA1c. So this makes the concept that fat wherever is fat, but it is especially abdominal fat, especially visceral fat, that is the biggest risk factor for insulin resistance, metabolic syndrome, and type 2 diabetes. During your MBBS days, there was always an MCQ question, which is the largest endocrine gland in the body, and we used to answer thyroid gland. Now we know it is no longer the thyroid that's the largest endocrine gland in the body. It is the adipose tissue, which was once considered a waste energy depot, that is now considered to be the largest endocrine gland in the body. And adipose tissue produces a host of hormone. Among them, the most important insulin sensitizing hormone is adiponectin. That is why the story of Pioglitazone is a story of adiponectin. So that is why many people think that if you're having type 2 diabetes, you have an adipocyte IV infusion. Many times that can correct type 2 diabetes, whereas type 2 diabetes is invariably obesity. But obesity shows that there is no adequate site for the triglyceride or free fatty acids to get deposited. So your adipocytes are getting overexhausted and the free fatty acids are roaming around in the liver, causing a fatty liver, roaming around in your pancreas, causing a fatty pancreas, roaming inside your muscle, causing an intramyocellular fat deposit, roaming around your fat, causing an epicardial fat deposition. So basically understand the largest endocrine gland in the body is the adipose tissue, followed by the thyroid gland. As your adipocytes get more and more bulkier, the adiponectin production comes down, whereas the tumor necrosis factor alpha, interleukin 6, and resistance increases. So roughly, whatever I've told in the first two slides, before we go for Pioglitazone, understand Asian or Indian is a thin, obese Asian Indian phenotype. We may be looking thin externally, but obese internally. So BMI cut for overweight for us is 23. BMI cut of obesity for us is 25. It is not the abdominal fat. It is not the external or subcutaneous fat. It's the visceral fat that is important. And once your visceral adipose gets more and more bulkier with triglyceride, your capacities to produce the adiponectin comes down and your insulin resistance goes on increasing. And liposuction is a cosmetic surgery, whereas a bariatric surgery is a metabolic surgery. It always cures your HbA1c. And what about the basic pathogens of type 2 diabetes? We know the differences, omnius octet, and the dirty dozen, and all the 15 pathogenic mechanisms. What are the basic three pathogenic mechanisms of type 2 diabetes? At first, there is abdominal obesity, fatty liver, insulin resistance. My beta cells fight to overcome the insulin resistance by compensatory hyperinsulinemia, undergoing progressive apoptosis. At the same time, the L and K cells of intestine are producing less of GLP-1 and GIP. Look at a person like me, age 44, 45 years. Suppose my HbA1c is 5.8. What is occurring in my body? I'm having abdominal obesity. I'm having fatty liver. I'm not exercising. My parents are having diabetes. My beta cells are trying to overcome the insulin resistance by compensatory hyperinsulinemia, but it is undergoing progressive apoptosis by oxidative stress. At the same time, my L and K cells of intestine is producing less of incretins. I can control the insulin resistance by diet, exercise, weight loss, metformin, and pioglitazone. I can give an incretin effect by a GLP-1 analog or an oral DP4 inhibitor, but I have no drug to prevent a beta cell failure. If there is a single drug to prevent a beta cell failure, diabetes never becomes a polytherapy. We don't have to go from metformin 1 gram BD to a gliptin, to a glitazone, to an SGLT2 inhibitor, to a sulfonylureas, to a basal insulin, to a basal bolus insulin. If there is a single drug to prevent a beta cell failure, you need to give metformin plus that drug, and the patient will live happily ever after till the age of 90 or 100 years with a persistent HbA1c less than 6.5. The only two drugs which can probably prevent a beta cell failure to some extent is an early incretin-based therapy or an early pioglitazone-based therapy. To understand this scenario, think of a newly diagnosed type 2 diabetes patient coming to you with an HbA1c 7.5. You are starting him on metformin 1 gram BD and you are calling back the patient after 3 months. So he is diagnosed at the age of 35 years with an HbA1c 7.5. You are starting on metformin 1 gram BD. After 3 months, he comes happily with an HbA1c of 5.8 to 6, telling the doctor, Dr. Bobby, you gave me a tablet just costing 5 rupees, 2 1 gram tablet. My HbA1c is controlled, doctor. I'm happy. Okay, you are asking the patient to repeat the HbA1c every 3 monthly for 3 years. After 3 years, in 80% of situations, he will come and tell me, Dr. Bobby, the tablet which you gave me 3 years was working for the past 6 months, doctor. My HbA1c is more than 8. I wanted to see you. So I checked my HbA1c yesterday also, it's 8.5. That shows that metformin was working initially for the first 2 years or 3 years. After that, again, your beta cell failure is progressing and your HbA1c is slowly rising. So metformin is a good drug in the pre-diabetic phase of diabetes when HbA1c is 5.7 to 6.4. Once your 50% of beta cells have failed, once your 4% of beta cell is failing per year, metformin alone may not be powerful. In that instant, that is where Verify study, that is where Adopt study, that is where all the Japanese studies concerning pioglitazone is important. The same patient coming to at the age of 35 years with an HbA1c 7.5. I am starting on a metformin gliptin, a Genumet, Galvasmet, Combiglisa, Gendadio, and asking the patient to come back after 3 months. He will come again with an HbA1c from 7.5 to 5.5. I'm telling you, don't worry. Continue the Genumet, Galvasmet, Combiglisa, or USV's Jalram, whatever it is, and keep on repeating the HbA1c every 3 monthly for 5 years. He will come back at the end of 5 years also with an HbA1c less than 7 in 80% of situations because of the beta cell neogenetic and anti-apoptotic property of an early incretin-based therapy. So that's the charm of an incretin-based therapy that gives glycemic stability and durability. The same thing can be expected if you give an early pioglitazone also. The same patient is coming and telling me, Dr. Bobby, I'm going to Canada per se, so I can't carry all the big tablets, doctor. I can't afford to buy 5 years tablets of your Jalram or Genumet. Give me some small tablets you can carry, which is cost friendly for me, so that I'll come back after 5 years. I'm going with my wife. I'm migrating to Canada. After 5 years, also, Dr. Bobby, my sugar should be controlled. So, guy coming with an HbA1c 7.5, I can either start him on a Galvasmet, Genumet, Jalram, and send him off and tell him, you come after 5 years, your HbA1c will be less than 7. That is shown by a verified study. Second, I'm putting him on metformin 1 gram BD plus a Pios 30 milligram and telling you go. This is a small tablet, but you go and you will come back after 5 years also with an HbA1c less than 7. That is pioglitazone shown by Adopt study, and all the Japanese studies shows that glycemic stability and durability with pioglitazone is much more compared to a gliptin or a liraglutide study over 7 to 10 years. So basically, it is the glycemic control that is important, but glycemic stability and durability that is always given with pioglitazone. Now we'll go to metformin and pioglitazone. I'll be touching and finishing in almost 12 more slides, but basic dictum. Thin obese Asian phenotype, adipocyte is the largest endocrine gland. Think of adiponectin. The younger adipocytes produce more of adiponectin. Once your adipocytes get more and more bulkier, your adiponectin production comes down. And glycemic stability and durability means that you are starting a patient on a tablet for diabetes. He comes after 5 or 7 years, even without monitoring, but doubly sure that HbA1c is going to be persistently less than 7. That is metformin with gliptin, metformin with pioglitazone. Why did I put this slide of metformin which was pioglitazone? Because metformin, we know metformin has many more effects beyond glycemic control. Metformin is just like vitamin D. Once upon a time, vitamin D was for rickets, osteomalacia. Now, vitamin D is everywhere. Dementia, depression, schizophrenia, upper respiratory infection, tuberculosis, corona mortality, Parkinson's disease, metabolic syndrome, malignancy. You name it, that is where vitamin D is there. Just like that, metformin, we know the maximum effective dose is 2 grams per day, approved for use in children above the age of 10 years. Drug of choice for youth onset type 2 diabetes. I didn't present for this. For the general practitioners like you and me to know, metformin is now the drug of choice for PCOS that we know. PCOS, Nash, HIV-induced lipodystrophy, prevention and delay of diabetes, add-on drug with prevention and delay of malignancy, especially CA+, along with doxorubicin. And one more thing, prevention and delay of neurodegenerative disease, including Alzheimer, Pics, and Parkinson's. So basically, metformin is for type 2. You know, it is for youth onset type 2 diabetes. That also you and me know. Metformin is for PCOS, NASH, prevention and delay of diabetes as an add-on drug with doxorubicin for CA+, and prevention and delay of neurodegenerative disease, including Alzheimer, Pics, and Parkinson's. And we know what is type 1 diabetes. Type 1 diabetes is insulin-dependent diabetes. What is type 2 diabetes? Okay, non-insulin-dependent diabetes. What is type 1.5 diabetes? It is the older name of LADA, or latent autoimmune diabetes. Latent autoimmune diabetes in adults. What is type 3 diabetes? Type 3 diabetes is the new name for Alzheimer's disease. The more obese you are, the more insulin resistant you are, the more building up of neurofibrillary tangles and A beta amyloid plaques in the brain. So metformin therapy in elderly beyond the age of 50 years with or without diabetes can prevent the progression of neurodegenerative disease, including Alzheimer, Pics, and Parkinson's. And metformin is thought to be a powerful anti-aging drug. That is why TAME study, which aims at decreasing the mortality of people and increasing the longevity for 100 years by starting metformin right from the age of 60 to 70 years. So metformin can be considered as an anti-aging drug. So Pio is thought to be a 2 to 3 times much more effective insulin sensitizer compared to metformin. But more studies of pioglitazone is in the field of metabolic syndrome, is in the field of fatty liver disease, is in the field of carotid intima reduction. But metformin, the studies are vast compared to pioglitazone. Many of the studies with pioglitazone are restricted to Japan and some other countries, but metformin you have studied so much. So metformin has gone beyond diabetes. At least understand, metformin is an add-on drug to doxorubicin. Metformin is considered to be an anti-aging drug, prevention and delay of neurodegenerative disease, including Alzheimer, Pics, and Parkinson's. Now coming to our star, that is invariably pioglitazone. So look at these slides, and I'll be finishing in 15 minutes. What is pioglitazone? Pioglitazone is a PPR gamma agonist. Why do I tell this? Many times many times even doctors, when we go for doctor, what is pioglitazone acting? Where does it act? How does pioglitazone was weighted? Just like metformin. Previously, during my MBBS days, so we had Sadostar and Tribadi, which used to say that mechanism of action of metformin is unexplained. Some used to say it inhibits the hepatic glucose output by inhibiting the hepatic gluconeogenesis. Some used to say it increases the peripheral glucose output or utilization by promoting anaerobic glycolysis. Now we know the key mechanism of metformin is activation of 5-AMP kinase. Just like that, what is the mechanism of pioglitazone? So pioglitazone is a PPR gamma agonist. Just understand that I have taken everything from Harrison only. PPR gamma agonist. PPAR are transcription factors or nuclear transcription factors. You have 3 PPR receptors: PPR alpha, gamma, delta. Just understand, PPR gamma agonist is pioglitazone. PPR alpha agonist is nothing but our fenofibrate, your Rosdaf, atorlipep, which is given for the treatment of hypertriglyceridemia. So PPR alpha is the site of action of fenofibrate. PPR gamma is the site of action of pioglitazone. PPR alpha gamma dual agonist is some people's favorite saroglitazone or lipaglyn, a drug which is used in the treatment of diabetic hypertriglyceridemia. But saroglitazone or lipaglyn is 1,000 times more agonist to PPR alpha compared to PPR gamma. So basically understand, pioglitazone is a PPR gamma agonist. PPR alpha agonist is fenofibrate, which is present in the Rosdaf. PPR alpha gamma dual agonist is nothing but lipaglyn or saroglitazone. And what is the mechanism of action of pioglitazone? Now understand, Pioglitazone is a PPR gamma agonist. PPR gamma is a transcription factor for conversion of free adipocyte to adipocytes. PPR gamma is a transcription factor for insulin sensitive gene. First and foremost, understand PPR gamma. Pioglitazone acts on the nuclear PPR gamma receptor. It is a transcription factor for insulin sensitive gene GLUT4 CETP lipoprotein lipase. Okay, we are all happy. But main mechanism of pioglitazone is a transcription factor for conversion of pre-adipocyte to adipocytes. Pioglitazone, whenever you take, suppose my mother is having the age of 71 years. She is having bone density, almost I did a DEXA scan, minus 1.5. Okay, in the osteopenic range, but it is much more normal compared to the age of 71 years. That is okay, minus 1.5. She was actually on glycomet trietofort, that is metformin to 1 gram, glimepiride 2, and voglibos 0.3 twice daily with the glixambi, that is 5 milligram linagliptin, and empagliflozin 25. All the 5 drugs together. Glycomet trietofort, 1 gram metformin twice daily, glimepiride 4 milligram once daily or twice daily split, voglibos there with the linagliptin 5 with an empagliflozin. What more I can give? She's hesitant to take any injection. Still her HbA1c is 8.2. My only last resort is nothing but pioglitazone. Okay, elderly, she may develop an osteoporotic fracture, but DEXA is normal. I have no other option. I have to put her on pioglitazone. So I started, her body weight is 71 kilogram, age also 70, 71. I started on pio 15 milligram. After 3 months, her HbA1c came down from 8 gram percentage or 8.2 to 7.5. I intend to keep her HbA1c 7.5. Only I don't want a too much less glycemic control in my mother of age 65 years having a hypoglycemia if the defense is stacking. I don't want. But ultimately, her body weight increased from 70 to 72.5. So her HbA1c come down by 1.5 gram percentage at the expense of a weight gain of 2 kilogram. So pio acts by weight gain. When you are giving pio, if a patient doesn't have weight gain, that means that pio is not at all working. So what is the mechanism of action of pio acting? Pioglitazone converts bone marrow progenitor stem cells to the adipocyte lineage. So my mother's bone marrow progenitor stem cells are created to new adipocytes. So my mother gets fat by having an abdominal obesity, a moon facies, a thoracocervical fat pad, a supraclavicular fat pad. My mother looks more bulky because new adipocytes are created in her subcutaneous tissue. What does this adipocytes do? My mother is already obese. So whatever free fatty acids there in the liver, causing a fatty liver, in the pancreas, causing a fatty pancreas, around the heart, causing an epicardial fat part, in the muscle, causing an intramuscular fatty acid content. All these free fatty acids drained from the liver, drained from the pancreas, drained from the muscle, and getting relocated in the subcutaneous adipose tissue. Just like you are having a flood and all your home is destroyed in the flood. So you are living and you are getting relocated in a shelter camp. Just like that. When we are obese, our adipocytes are overexhausted. So whatever extra free fat is in adipose and triglyceride gets deposited in the liver, causing a fat liver, fatty pancreas in our muscle, causing a fatty muscle. But when you take pioglitazone, you get more fatter because your subcutaneous fat is more and more increasing. So your subcutaneous fat acts as the storage site of whatever free fat is that is there in the liver and muscle. So whatever fat is there in the liver is going to the subcutaneous deposit. Whatever fat is there in the muscle is going to the subcutaneous deposit. And ultimately, your liver and muscle is getting free of all the fatty. That is the mechanism. Understand? This is a person giving pioglitazone before and after 16 weeks. Look, the subcutaneous fat has increased from 144 to 204. So he's getting fat, but the fat is deposited in the subcutaneous fat. But the visceral fat is coming down from 140 centimeters squared to 105. So pio acts by causing weight gain. Always understand. So the mechanism action of pioglitazone is causing weight gain by producing new adipocytes. So when you take pio, you get fatter, your mother gets fatter, your patient gets fatter, your father gets fatter, because invariably because of the new adipocytes that's created, these adipocytes drain the fatty acids from the liver and the muscle, and the liver is getting drained of the fatty acids. That is why now pioglitazone is thought to be the first line drug of choice for a Nash or a non-alcoholic steatohepatitis. Because when you give pioglitazone, what happens? I am fat, I am eating more and more fatty food and abdominally obese. My liver is getting loaded with fatty acids. If I don't exercise, my liver is getting exhausted. My liver is going to steatosis and fibrosis. So once I take pio, what happens? My adipocytes are getting more and more number is increased in my subcutaneous fat. My belly size is increasing, but that belly size is increasing because the fatty acids goes from the liver to the subcutaneous fat, and my liver is getting totally free. That is why now the guidelines is that pioglitazone reduces Nash by 75%, and only anti-diabetic drug which can prevent the progression of fat liver disease to hepatocellular carcinoma by 50% is pioglitazone. So whenever you take pio, you have weight gain, and the mechanism of action of pioglitazone, understand, it is by adipocyte recruitment and adipokine production. So whenever you take pio, you need a weight gain. If there is no weight gain, there is no pio action. You know that the patient is not taking pio, or the patient is underdosing pio. The weight gain is due to redistribution of fat from the visceral fat to the subcutaneous fat, and the new adipocyte. I told you, adiponectin is a very powerful insulin sensitizing hormone. So pio creates new adipocytes, and the new adipocytes which are produced produce more of adiponectin, which is thought to be highly insulin sensitizing. So that is why new adipocyte that is created is pioglitazone, and pio acts by weight gain, but that's a metabolically healthy obesity. So metformin is an insulin sensitizer, it causes probable weight loss, and pio is an insulin sensitizer which causes weight gain, but weight gain is always a positive weight gain. And this is the why when you take pio, your father, mother, your patient gets fatter, but the visceral fat, which is the metabolic fat, comes down, and the subcutaneous fat increases, and this subcutaneous fat loads the free fatty acids, and the liver is reduced by Nash, your muscle is reduced of fatty acids, and you have a highly powerful insulin sensitizing action. Now, going to the controversies and the effect of pioglitazone. Yeah. So efficacy of pioglitazone. Now we are slowly touching, and I'll end up and finish in 10 minutes. But basically, building blocks. I don't know how many doctors are there. We don't reciprocate because that's the problem with webinar. You are seeing a doctor one by one in the eyes. You know how much they are getting convinced. But basically, understand. I'm just telling science what you have to know. So thin, obese Asian Indian phenotype. The largest endocrine gland is adipose tissue. Only two drugs which are having beta cell neogenic anti-apoptotic property to prevent the beta cell failure, giving a glycemic stability, durability. You are having a patient who is telling, doctor, I'm going abroad, coming after 5 years. I need to keep my HbA1c less than 7 after 5 years. Put him on a metformin, gliptin, genumet, gandasmet, Zalrai. Send the patient on a metformin, Pios 30. Ask the patient to come back after 5 years. It is going to work. And pioglitazone acts by creating new adipocytes. Your father, mother, whoever takes pioglitazone gets more fatter. It is because of the fat redistribution from the visceral to the subcutaneous fat, and your fat liver and fatty muscle comes down by 75 to 50%. And how does pioglitazone act? Pioglitazone is a transcription factor agonist, so it acts very slowly. The most rapidly acting antidiabetic drug is insulin. Second is sulfonylurea. Third is gliptins. And fourth is nothing but SGLT2. Everything else. Insulin acts in 30 minutes. Sulfonylurea acts in 48 hours, gliptin acts in 48 hours, SGLT2 acts as early as 24 hours. But what about pioglitazone? Pioglitazone starts its action by 3 to 4 weeks, and the optimal glycemic control is reached by 12 weeks. That is why we know DCGA abruptly withdrew pioglitazone in June of 2013. What happened? We know we were all in panic. That time we were not well used with gliptins per se. SGLT2 was not in the scenario. So many of the doctors were writing all the triple drug combination, especially US-based triglyceride 2 for myself and thousands of patients on triglyceride 2 7.5 1 gram twice daily. Abruptly, June 2013, PIO is withdrawn. What is going to happen? Can you call back every patient and start everyone on insulin? No. What did the doctors do? 90% of the patients switched on pioglitazone with voglibos. That is what happened. Voglibos market increased like anything that time, and slowly only gliptin market picked up. So many of the doctors converted that triglyceride 2 for to glycomet prior to 4, so that pio component was filled with voglibos, or amaryl MP2, amaryl MV2 became glucanone MP2, become glucanone MV2. Everything was substituted with voglibos, and doctors and patients were happily looking. First 2 to 3 months, nothing happened. After 3 months, patient came with HbA1c skyrocketing 10 and 12 with a blood sugar 300, 400, because pio is a transcription factor agonist. The effect occurs very slowly, and the effect disappears also very slowly. So once you withdraw pioglitazone, after 3 months, the HbA1c shot up. So we know alpha glucose is nothing in front of mighty pioglitazone. What does alpha glucose do? It inhibits the reabsorption or digestion of a disaccharide to monosaccharide. It delays the absorption of glucose. But where is the mighty action of pioglitazone by reducing the insulin resistance? Where is the less mighty or a similar action of alpha glucose? So pio acts slowly, and the effect comes slowly. When you disappear or withdraw, the effect goes off also slowly. But understand, pioglitazone is a category C drug, which is not used in pregnancy. So polycystic ovary syndrome patients who is intended for conception need to take metformin, not pioglitazone, because animal study have shown that pioglitazone can cause fetal limb retardation. Whereas metformin, glibenclamide, and insulin are category B drug. So this much understand the basis of pio. So pio is always an effective insulin sensitizer. When you give pio, you have to gain weight, Pio drains out the fat from the liver and muscle, reduces the Nash by 75%, reduces the hepatocellular carcinoma progression by 50%, reduces the fatty muscle by more than 50% per se. But don't give Pio in pregnancy or PCOD patient going for conception. Give Pio 7.5, 15 or 30. The standard dose is 15, higher dose is 30, low dose is 7. That's what Japanese studies say. Low dose Pio 7.5, standard dose is 15, high dose is 30, and supra high dose or supra maximum dose is 45. The dose of Pio for Nash and hepatocellular carcinoma is thought to be 30. Connection is unstable. Hello. Can I continue?
Yeah, please continue. Please
Yeah,
continue.
yeah. Because I don't know whether somebody is hearing me because my camera is getting off.
Oh, no, we can all hear you well.
Okay, thank you, sir. So what about the adverse effect of pioglitazone per se? So basically, side effects and effects of pioglitazone is dose. When I told you, pio is a slowly acting drug. It starts action by 4 weeks, optimal glycemic control by 12 weeks. Absolute contraindication, always remember, NYHA 3-4 cardiac failure, don't give. Clinically significant macroedema, don't give. Clinically significant osteoporosis, don't give. Edema occurs in 5% monotherapy, 10% combination with sulfonylurea, 15% in combination with insulin. Edema occurs more commonly in obese patients, especially ladies with varicose vein, concomitant use of NSAIDs, calcium channel blocker, and patients having macroalbuminuria. So an obese lady coming, especially with varicose vein, who is bedridden and more than standing for a longer time, who is already on a calcium channel blocker, who is having a macroalbuminuria, then you know the chance of pio-induced edema, especially orthostatic pattern, is very high. But how do you control a pio-induced edema? Suppose my mother or any other lady who is coming and telling, Dr. Bobby, I've been taking triglycinase 215 by 500 for 10 years. My HbA1c is 6.2, doctor. I'm having very bad edema. I know that it is this drug that is causing edema, but I tried many other drugs. I don't want an injection. My HbA1c is 6.2. You control my edema in some way and give me, but I want to continue the drugs at any cost. Just like some people come and say, whatever it is, I want this drug only. This drug has worked for me. So how can you control a pio-induced edema in a patient who is already on a 30 milligram pioglitazone? Okay, you can try to reduce the dose of pio, but it's not going to work. It will invariably reshoot the HbA1c. Number second scenario, you can add on an ACE or ARB with a thiazide-like diuretic, probably a chlorthalidone or indapamide. You can make it Telsar CH, Olmesar CH, Olmesar CH, whatever it is. And now the drug of choice of pio-induced edema, Vijay Vishwanathan group has already published in 2008. It is nothing but aldactone, spironolactone or aldactone, 25-50 milligram. Many of these obese ladies have received some idiopathic hirsutism PCOD. You add on an aldactone, 25 or 50, the pio-induced edema always disappear. So basically understand pio, the effect and side effects is dose dependent. Dose more than 15 or 30 can produce edema, especially in a combination with sulfonylurea and insulin. But pio-induced edema, if the patient is not able to withdraw the tablet, put on an aldactone. And weight gain, I told you, weight gain is the mechanism of pioglitazone. My mother is starting pioglitazone with a body weight of 70. Her HbA1c comes down by 1.5. That means that her body weight has increased by 3 kilograms. HbA1c reduction of 1 gram percentage is associated with an increase in body weight by 2 to 3 kilograms because pio acts by conversion of bone marrow progenitor stem cells to the adipocyte lineage. So my mother is taking it, she's getting more fat. That means that more adipose tissue is created in the subcutaneous tissue. And adiponectin is produced more and more. Her free fatty acids are getting deposited in the subcutaneous adipose tissue, and HbA1c is coming down and down. So 20% of weight gain in pio is only due to edema. 80% is due to fresh adipose tissue formation. That is why many people now believe that IV adipose tissue infusion will become the treatment one day for type 2 diabetes because more and more adipose tissue is there. It's just like your neurons. We know the number of neurons in the brain is 10 raised to 12. Number of synapses by a single neuron is 10 raised to 3. So total synapse is 10 raised to 15. Then there is only degeneration of the neurons. You're activating the neurons by constantly increasing your memory, exercising, controlling your metabolic fluid. Just like that, your adipocyte number is totally finished by 15 to 18 years, just like your peak bone mass. Then your adipocyte number doesn't increase. My body weight at the age of 18 years, my body weight was actually 67 kilograms. Now I'm 85 kilograms. I'm not a Salman Khan to have a muscle mass. Remaining almost 22 kilograms for me is fat tissue. Where is the space for my free fatty acid deposit? It is my liver and my muscle. So invariably I have to create more and more adipocyte by taking pioglitazone and reduce the Nash. And this is the norm of pioglitazone. That is why pio produces osteoporosis. Told you the mechanism action of pioglitazone is conversion of bone marrow progenitor stem cells to the adipocyte lineage. So more and more bone marrow progenitor stem cells is converted to adipocyte, not to osteoblast. So osteoblast size and number is invariably coming down. So pio has to cause osteoporosis. So the side effects of pio is fluid retention, edema, weight gain. This is actually not the side effect. It is the effect of pioglitazone. It can cause edema. It can cause weight gain because it's a mechanism of action. And osteoporosis should be there because pio, everything is created from the bone marrow, progenitor stem cells. It is converted to adipocytes. So actually the osteoblast number is coming down. And there is hip and generalized fractures more commonly in postmenopausal female. What is the percentage and what is the most common site of pio-induced fracture? It is not spine or hip fracture. It is actually calcaneal fracture. So many studies have shown, including my patient. I mean, evident use of pio in this country is Actos for the past 10 years. Actos 30, so many patients have, but men, more than 30 milligram for more than 11 years in my practice. Same Actos, Takeda's American brand I'm using in this country for 11 years. No bladder cancer from my experience. I would have treated not huge, maybe 10,000, 12,000 for this 10 years, not per year. 10,000 or 11,000 with pure Actos. Only not even one case of bladder cancer. But you ask me how many cases of fracture you have seen. At least I have seen 1 to 2 fracture per year in ladies. Some people come and say, some people don't tell at all. One lady was telling me 6 months back, Dr. Bobby, I'm continuing Actos. But I got down from a car, my chapel just slipped like that, doctor. There was a small fracture in the behind the posterior aspect of chapel. It was nothing but an osteoporotic calcaneal fracture. Some people have a very bad Colles fracture per se. So the pio-induced fracture most commonly occurs never in the spine and hip. It is a collis and calcanea. That is the norm because pio acts by causing osteoporosis. Pio acts by creating more and more adipose tissue. And these are the side effects of pio. But I told you, pio causes side effects because of its mechanism of action. Pio has to cause weight gain. Pio has to cause osteoporosis. So choose patient vigilantly and choose the dose of pios vigilantly. Now, I mean, the fate of pio. What happened to pio? We have heard in newspaper and our Sanjay sir, everything is there. But ultimately, we know an article written by Shashank Joshi sir in Jappy or something where he has told the concept that drugs can kill man, but man can also kill drugs because drugs can be killing man, but man can also kill drugs in some way or the other. And say Pio didn't kill anyone, but humans killed Pio. That too between the period of 2006 and 2016. What happened? All the controversies. Pio was launched in the market 1999. Pio, rosiglitazone was slowly, Avendia, the Cipla was slowly moving out. Glaxo was slowly moving out with Avendia or rosiglitazone 2 and 4 when I was doing DM. But ultimately, Pio was booming from 1999 to 2005. 2005, Nissan's meta-analysis came, which shows that rosiglitazone may have an increased risk of cardiac events. Okay, people think that is rosiglitazone, but the bad aura spell on pioglitazone also. 2010, French medical agency reported that pioglitazone may have an increased chance of bladder cancer. That was the new name, CA somewhere. Cancer somewhere, even inducement large, something somewhere, or NDMA with metformin. Now, invariably, ranitidine is blocked in some country, X4, valsartan in US is blocked. So, anywhere you tell cancer, then people start blocking the drug like anything. So, 2005, Nissan's meta-analysis, ROSI, 2010, French medical agency, and 2013, June, DCGA withdrawing Pio. That was the end of Pio. So, Pio was at its peak, then was the death of Pio between 2006 to 2016. Millions of doctors who have been writing Pio were hesitant to write Pio because of the fear of bladder cancer, osteoporosis, weight gain, cardiac risk, because of the fear what will my colleagues think, including me who was writing Pio at that time. In this country, invariably some of the Indian patients go to India, this drug is withdrawn. We are not buying Actos. Actos is costly here. Buying from India, you gave me a drug which can cause cancer. So including the doctors who are avid followers of Pio, got hesitant. Suppose I write this, what will other doctor think? What will the patient think? Will the patient miss from me? So invariably, millions of doctors who have been writing pioglitazone, Vikram pioglitazone, because the fear of some complication, millions of patients who are relying totally on pioglitazone, invariably they're not taking or hesitant to take pioglitazone in a compliant manner because the fear of bladder cancer, osteoporosis, obesity, and the risk of whatever malignancy occurring somewhere else in the body, and the risk of cardiovascular. That time it was not evident whether Pio only causes increased cardiac failure, the ischemic cardiovascular can be reduced or not. That time the sales of Pio just came down like anything. Rosie was totally out. Pio market slashed to less than 8% of the pre-existing market. None were writing Pio except in certain pockets. And that was the rise of Gliptin, Sipta, Vilda, Saxa, Linda. They flourished like anything. 2006, 2013, every day, every endocrine in the city or every physician in the city was giving some talk for Sipta, Genovia, Vilda, Galvas, Saxa, Onglisa, and Linagliptin, Plagenda, Boringer, Lilly. We were giving talks like anything. But ultimately, every good person cannot be suppressed for a long. Every good star or a film star also cannot be removed. He will come back with a super hit. One day he is having the ability. That's how that happened to Pio. And slowly we know from 2006 to 2016 was the stalemate or that period of Pio. 2016, we have the 10-year follow-up data, proactive study, which shows that the chance of bladder cancer or any other cancer is less than placebo in Pio. Even now, the controversy of bladder cancer Pio exists. But understand, none of the patients who have been given pioglitazone has developed bladder cancer by whatever observation studies in India. We have more than 13,000 patient data, sir, and all. I publish so much data in JAMA. For my personally, I am not a diabetic practitioner who sees 100 patients per day. I am a Sadharana ordinary practitioner who sees 30 patients per day. Among them, 20 or 22 are pure cut endocrinology, 8 or 10 are diabetes. Among them, 90% of my patients who are not that obese, who are having poor glycemic control, I put on Actos. I have been used for 16 years of my practice or 10 years. I have not even seen one case of bladder cancer, but fracture I have seen. My experience is not important because I am not a researcher. I don't have any paper to prove myself. But whatever proactive data, 10-year follow-up data shows that the chance of bladder cancer or any other cancer is less than placebo with pioglitazone yourself. And that was the surge of Pio. Just like our national leader who came back from off all the aftermath, he rose away, just rose like anything. Just like that, Pio had to fight all the obstacles, and the boon for Pio was Pio reducing Nash. Ultimately, it is not the bladder cancer risk that is bladder cancer risk that was out that gave birth to the rebirth of pioglitazone? No. Ultimately, pio reduces NASH. NASH is where pio click. Pio reduces NASH by 75%. Pio reduces the progression of NAFLD to cryptogenic cirrhosis and hepatocellular carcinoma by 50%. Because look at the predecessor of pio, proglitazone. Proglitazone was banned in 1992 because the fear of hepatocellular toxicity or pulmonary hepatic failure. The same predecessor, where proglitazone was thought to cause pulmonary hepatic failure, that pioglitazone became the drug of choice for non-alcoholic steatohepatitis and reduction of hepatocellular carcinoma. And 2006, again, IRIS study came, which shows that pio is the most important anti-diabetic drug, which causes significant stroke reduction by reducing carotid intermediate exit. So that is the rise of pio. After that, all the international organizations
Yeah. I think the connection is a bit unstable. Dr. Matthew, if you could switch off your video, perhaps then the voice will be better. While we wait for Dr. Matthew's connection, while we wait for the connection issue to get resolved, let's just summarize. Yeah, I think you're back, Dr. Matthew. Yeah. While we wait for the connection to resolve, let's just summarize what Dr. Matthew has shared with us so far. Pioglitazone is a drug with a great pedigree, with great data to back its use. It is efficacious in glucose control. It is quite safe, well tolerated. It has multiple benefits. And actually, the proactive trial, the CVOT was done more than a decade before we realized the importance of CVOTs. Unfortunately, various things happened, and it perhaps got caught on the wrong side of global medical politics or pharmaceutical politics. Dr. Bobby, I think you're back now.
Sir, can you hear me?
Perfect. Yeah, now you're back.
Okay.
Perhaps we can
Thank
start
you.
again with the beginning of this slide, the one that's going on.
Okay, sir. Okay, sir.
Yeah.
So I'm audible. No, that's the only thing.
Perfect.
I
Now it's
lost the
now
video.
it's perfect.
Okay.
Yeah.
Thank you, sir. So, and the advantage of pioglitazone, sir was summarizing. So, pio, a drug which has stood the test of time, whatever English I'm using, stood the test of time because he had so much competitors to compete with him. All the mighty drugs, because including ADA 2022 guideline, which sir has put up. Look, pioglitazone is put in the list. Metformin 1 gram BD fails. No documented atherosclerotic cardiovascular disease. Where cost is a concern. So, in India, pio is a cheap drug. Pio 30 milligram costs you 8 rupees. Internationally, you look at the downward by ADA guidelines. In some countries, pioglitazone may be more costlier than SGLT inhibitor or a gliptin, and pio is one of the most costliest drugs, even costlier compared to Genovia, even costlier compared to dapagliflozin per se at some instance. But pioglitazone, midst of controversy 2006 2016, but it came back because of low bladder cancer, but more important, protection of NASH, protection of hepatocellular carcinoma, and strong reduction in stroke incidence per se. But don't give pio. Always remember NYHA 3 for cardiac failure. A patient with ischemic heart disease you can already give. And pio reduces HbA1c by 1.5 to 2 gram per cent. We know the maximum reduction in HbA1c is by nothing but insulin. Insulin can bring down the blood sugar from 500. A patient when hyperosmolar non-ketotic state to a hypoglycemic coma. And second is sulfonylurea 1.5 to 2 gram percentage. Pioglitazone reduces HbA1c by 1.5 to 2 gram percentage. Your gliptin and SGLT2 inhibitor reduce HbA1c by 0.8 to 1 gram percentage. And higher the baseline HbA1c, higher the HbA1c reduction. Understand, Pio is a very potent oral antidiabetic drug. The most potent oral antidiabetic drug is probably pioglitazone, then sulfonylurea. Now we know oral GLP-1, oral semaglutide, ribacillus, irrespective of all HbA1c baseline, it will reduce HbA1c by 1.5 gram percentage. Superior to that is nothing but pioglitazone. But Pio acts very slowly, and invariably the effect disappears also slowly. But stop pioglitazone, be cautious. It will have a shooting of HbA1c after 3 months. And what about the glycemic stability and durability? I told you the two drugs which can provide a glycemic stability and durability. Your diabetic treatment is a metformin gliptin therapy and metformin pioglitazone therapy. So that is very, very important in a person who cannot have a constant contact with the doctor. I myself have now some patients who are standard. So Mallu Christians, nursing staff who are working in New Zealand, who are working in Australia, who have not touched Kerala for the past 3 years, their husband without insurance living with them. They all are diabetic. So they are asking a single drug which can give a glycemic stability. They can't even afford for HbA1c because many times insurance is not covered. It is either a metformin with a gliptin or metformin by an Actos from Australia, by an Actos from New Zealand. Just take it, your guys. It is your husband. Nothing is going against it. Just take an Actos. So the first study which shows the glycemic stability and durability with pioglitazone was ADOPT study. Because ADOPT study in 2006, we know they've selected 4,000 patients with newly diagnosed type 2 diabetes patients. They were divided into 3 groups. First group was given glibenclamide or glyburide. Second was given rosiglitazone. Third was given metformin. And the patient were followed up a period of 4 years. So monotherapy, newly diagnosed type 2, rosi 4 milligram, glibenclamide up to 10 milligram, metformin 1,500 milligram, and the blood sugar was followed for a period of 4 years. The lowest monotherapy failure was with rosiglitazone. So you are giving pioglitazone 15, you are giving a metformin 1,500, glibenclamide 10, but after 5 years, 80% of the patients on Pio never required a second drug, whereas 60% of the patients on glibenclamide required a second drug. That shows the glycemic stability and durability because the beta is a neogenic and anti-apoptotic effect. This has been shown by innumerable number of Japanese studies, which is shown here. And what about Pio and cardiorenal protection? Now I'll be finishing in 3 more slides because this is very important step. And what are the positive effects of Pio? First, we showed the beneficial effect. What's the mechanism of pyoadipose tissue? That itself is the side effect, fluid retention, edema, weight gain, osteoporosis. That is because of the mechanism of action. What's the benefit of Pio? Pio gives a potent HbA1c control. Pio gives a glycemic stability more than your incretin-based therapy of 5 years to 12 years. Documentation of beta and neogenic anti-apoptotic documented by Japanese study. What about stroke reduction? IRIS study, a landmark study in 2016, which shows that almost 4,000 newly diagnosed ischemic stroke patients, understand? Ischemic stroke patient or newly diagnosed TIA patient without diabetes with insulin resistance. So patient with ischemic TIA or ischemic CVA with no diabetes, but with IR, with HOMA IR more than 3. So none of the patient had diabetes. They were given high dose of pioglitazone of 45 milligram versus placebo, and the patient were followed up for 4.8 years. Understand? Patients with ischemic stroke without diabetes, with IR, insulin resistance, with HOMA IR more than 3. Were given just Actos 45, Pio 45, and placebo, followed a period of 4.8 years. The second incidence of macrovascular disease, cerebrovascular, cardiovascular disease was 9% only in pioglitazone users, whereas it is more than 11.7% in patients who were on placebo. So Pio significantly reduces the atherosclerotic risk and stroke reduction by reducing the carotid intima media thickness. So understand, pioglitazone is a good agent in ischemic atherosclerotic cardiovascular disease, but not when the patient develops a cardiac failure with reduced ejection fraction. There you have better agents of SGLT2 to give. So once you don't have a cardiac failure, give pioglitazone. What about Chicago study? The same study, pioglitazone and glimepiride was given in newly diagnosed type 2 diabetes patient, and the carotid intima media was followed up for 2 years. Carotid intima media thickness came down in pioglitazone, whereas it went up in glimepiride. So this is what pioglitazone is. So basically, I'm just summarizing and coming to the last thing with Nash. Nash is very, very, very important. But with Nash slides, I'll be stopping. But understand, Pio is a very potent anti-diabetic drug. But understand, low dose is 7.5, standard is 15, high dose is 30 to 45. 30 to 45 preferably give in Nash patient. Don't give when you have contraindication of NYHA 3-4 cardiac failure. Osteoporosis is the mechanism of action. It is one among the effect of the mechanism of action. Don't give in patient with very bad bones, or if you are giving, give in a lower dose. Fracture most common in the calcaneal and Colles fracture, not spine and hip fracture. So whenever you give pioglitazone, think that the effect occurs slowly by 3 months. But you give pioglitazone invariably, you have an HbA1c control, you have a glycemic stability and durability, you have significant ischemic atherosclerotic cardiovascular protection, as shown by IRIS study, Chicago, Periscope, and all the studies, and proactive study, everything significant atherosclerotic cardiovascular protection. And this is the effect of pio on Nash. Now, Nash is very, very important because we know 75% of Nash patients. Nash nowadays goes to gastroenterologist. But in Harrison, endocrinology and metabolism as Nash, endocrinology and metabolism as osteoporosis, because we know even now osteoporosis going to rheumatologist and orthopedician. And Harrison dyslipidemia also with endocrinology and metabolism only in our Bible, Harrison, but the same with Nash, because we know gastroenterologist doing hepatitis B, C, anti-LKM, antibody giving Udilip, and just all the Silibon, Camilari. Even in this country, we see people taking Himalaya pharmaceuticals like anything, people getting confused. What is the treatment of Nash? So basically understand the concept. 75% of the patient with NAFLD or Nash die of a coronary artery disease. 20% of patients with NAFLD NASH die of cancers other than liver cancer, maybe a CA breast, CA colon, CA endometrium, CA pancreas, a Barrett's esophagus, or a CA gallbladder per se. Only 5% of NAFLD patients die of a hepatocellular carcinoma or a hepatic failure. So NASH or NAFLD is a part of pure metabolic syndrome. Your visceral adipocytes drain into the liver. And the drug of choice of Nash is nothing but pioglitazone. This NEJM study, everything shows, I told you, the mechanism of pio is conversion of the bone marrow cells to the adipocyte. So when you take pio, your abdomen is bloating up. My mother is having moon facies, buffalo hump. That is because of new adipocytes, but that new adipocytes are filled with the fatty acids from the liver, and liver is getting totally drained of the fatty acids, and pio reduces Nash by 75%. Look at the slide, and pio increases the adiponectin level by this slide by almost 50%. And this is the latest diabetes care algorithm for treatment of Nash. So understand this first sentence. So among the anti-diabetic drug or hepatoprotective drug, maximum Nash reduction is with pioglitazone 45 and 30. Look at the slide first, 45, 30. Second Nash reduction maximum is with GLP-1 and now that time is with liraglutide Victoza. Now it is semaglutide Ozempic, maximum Nash reduction. Third maximum is with vitamin E. One single word about vitamin E. Many people you write, when we write vitamin E 400 mg BD, some people come and say, Doctor, vitamin E has side effect per se. And some ladies even now come and ask, Doctor, I read that Karina Kapoor and other ladies are applying vitamin E on the face. So can I apply vitamin E on the face for my anti-aging effect? So basic thing of vitamin E, understand the required dietary elements of vitamin E from SPM Park or Harrison is 22 milligram per day. But antioxidant property of vitamin E comes at a higher dose of 400 milligram BD. So when you are giving vitamin E as an antioxidant, given a higher dose of EBIT or EBION, 400 milligram BD. And that is why American Association of Study of Liver and European Association of Study of Liver have shown that the first line drug for Nash is pioglitazone, followed by vitamin E. You can give pioglitazone or vitamin E or a combination of both in uncontrolled Nash that is not controlled by lifestyle per se. So gone are the days of Camilari, gone are the days of Silibon, gone are the days of all the herbal preparation. You know, if it's a pure Nash, you have to reduce your fat from the liver. That you can give 5-AMP kinase activator, Metformin, that's only 20% effective. You can give a drug which promotes the new adipocytes and removes fat from the liver per se totally and reduces the hepatic fibrosis. That is nothing but pioglitazone. But pio in Nash is 30 and 45 milligram. Pio for diabetes is 7.5 and 15 milligram. And one more previous slide, and pioglitazone and albumin, we know, irrespective of GFR, pio reduces micro and macroalbuminuria up to 18.5%. And that is pioglitazone. And this is the take-home message. And the last slide, which I'm going to tell. So basically, what is pio? I'm just concising. Pio is a drug which was launched in 1999, which was flourishing till 2006. After 2006, it was totally cancelled from the brain of the doctors, mind of the doctors, and brain and mind of the patients per se for controversy, bladder cancer, obesity, osteoporosis, cardiovascular, resurgence of pioglitazone 2016, fighting against all the mighty people. I was asking this USP people that how many CME you have conducted in this podium, 597. I've asked them how many CME for pioglitazone. This is the third CME for pioglitazone. You ask any doctor how many talk do they give for pioglitazone, how many talk do they give for SGLT inhibitor, DAPA, CANA, EMBA, or a GLP-1 or liraglutide, Victoza, or oral semaglutide ribosylase, because the market controls. Because a drug which costs you only 5 rupees or 7 rupees, but it's a mighty drug, it has to compete against all the mighty giants. But still, Pio has stood the test of time, beating all odds. That's why I tell you, a cheap drug, 15 or 30 milligram, costing you 5 or 9 rupees, reducing HbA1c by 1.5 to 2 gram percentage with no hypoglycemia, healthy, metabolically healthy weight gain, reduction of Nash, reduction of hepatocellular carcinoma, reduction of stroke, reduction of nephropathy, but always respect the contraindication, respect the indication. Because when you have NYHA 3-4 cardiac failure, clinically significant macroedema, clinically significant osteoporosis, don't give. When you have a patient with no risk factor where Pio is of concern or Pio is useful, give it. In a patient with Nash also, you can give Pio, just like metformin. Some people use, doctor, can metformin given in PCOD cause hypo? How does it cause hypo? It's an insulin sensitizer. As pioglitazone with metformin given in Nash cause hypo? Nothing. It's an insulin sensitizer. The sulfonylurea cause hypo. This never cause hypo. And this is the algorithm for treatment of type 2 diabetes, latest 2020. The same thing. Metformin 1 gram BD fails right side, ST2 inhibitor GLP-1 now. Once metformin 1 gram BD fails, no documented atherosclerotic cardiovascular disease where cost is a concern, go for sulfonylurea, pioglitazone, or a low cost insulin. Where hypo is a concern, there also go for a GLP-1 analog, ST2 inhibitor, gliptin, or pioglitazone. So ADA guidance made is very clear. Metformin first choice, SGLT2, GLP-1 analog, atherosclerotic heart disease, or patient with nephropathy or chronic renal failure or cardiac failure. No atherosclerotic cardiovascular disease where cost is a concern, you give Pio 7.5, 15 milligram. No atherosclerotic cardiovascular disease where hypo is a concern. There also give pioglitazone. And in a scenario like India, it is not among only this guidelines. There are certain group of people who doesn't want a weight loss. We think that all the people want a weight loss. No, there are up to 40% of the people who are afraid of weight loss. Even now, some people come and say, doctor, I have developed diabetes, doctor. I should come drug doctor. I'm losing weight, doctor. People are telling that I'm getting older. So previously, any person who want weight gain, we used to put nothing but insulin. Now, 30% of people think that you are losing weight, you are looking old, especially ladies, perimenopausal age group, where the charm is going with an FSH going up, AMH coming down, and estradiol coming down. There you put on Pio, they get so happy. They think that, oh, doctor, my cheek has flourished, my abdomen, my buttocks, everything has become more better. I'm looking good. So there are offbeat indications also. And Nash patient, invariably, it goes for Pio. And this is the last slide, sir. Type 2 diabetes is not sugar alone. Type 2 diabetes is a part of metabolic syndrome. Keep your HbA1c, BP, cholesterol control. Check your retinopathy, neuropathy, nephropathy. Go for a TMD, routine periodontal checkup. When periodontitis is the sixth complication of diabetes, and routine supplementation is no longer recommended by ADA, but vitamin B12 may be checked annually in long-term metformin users. And late night sleeping, late night dinner, and cutting of breakfast now increase chance of diabetes by 30%. And whatever corona time, we know sitting is the new smoking, salt is the new cigarette. You sit for 30 minutes, get up and move for 5 minutes. Salt you recommended is 5 gram. We people take 15 to 20 gram of salt per day. So diabetes is diabetes, but none of the diabetic patients die of high blood sugar. They die of NAFLD, they die of coronary artery disease and nephropathy. And pioglitazone, it is not a lost drug. It is a lost drug, but it's regained like anything, a cheap drug, but use and don't declare the use because of fear of cancer, fear of weight gain. Understand with clarity and then use pioglitazone. Thank you so much, Sanjay Kalrasa and other people.
Thank you, Dr. Matthew. That was a great discussion, and you've touched not only pioglitazone, but you've been able to touch the entire concept of diabetes control, comprehensive diabetes control. So, thank you for that. And
Thank
basically,
you.
what you've done is put things in perspective for all of us. Quite a few questions waiting for us, Dr. Bobby. So, one question is from Dr. Gangadhar. He asks if pioglitazone can be given in people with CAD, coronary artery disease, without heart failure. I know that you mentioned that, but can you repeat the message again, please?
Yes, sir. So basically, pioglitazone reduces ischemic atherosclerotic cardiovascular disease by reducing hyperlipidemia, albuminuria, endothelial dysfunction, and reducing the procoagulant factors. So you can save. That's what proactive Chicago iris trial. Ischemic atherosclerotic cardiovascular disease you can safely give. But once the patient develops a cardiac failure or ejection fraction is coming down, then Pio causes adverse effect of flow differential and weight gain. So otherwise, Pio is totally safe. From what I know, Sanjay Kalra will tell the final word.
Safe, so don't hesitate in using it actually. Feel free to use it. Another question from the same doctor is why was 7.5 milligram Pio combination banned?
Yeah, sir, I don't know why it was banned per se, but internationally, from whatever minimum dose of pioglitazone is low dose pioglitazone, 90% studies come from Japan. That's the country where it's used. So 7.5, 15, 30, that is existing in Japan. And low dose pioglitazone is 7.5. Why that is withdrawn, I don't know. But many times, for me personally, I never got any benefit with 7.5. I always got a benefit with 15 milligram, 7.5 twice daily. Why it is banned from the company point of view, I don't know. PIO 30 was invariably withdrawn during after
Mm.
DCGS withdrawal. PIO of 30 didn't come back. Why 7.5 500 didn't come back? That I don't know, sir. Sanjay Kalra, sir, any other?
But yeah, but in Japan, 7.5 is easily available and is a very
Yeah.
popular drug there. Also, in our country, 7.5 you can get as triple combination. So that is still available. So don't worry about it. You use whatever is required for your patient. And mostly it will be 15 milligram that will be
Yes,
required,
sir.
like Dr. Matthew said. You've talked about the role of pioglitazone in Nash, the fact that it is actually first line therapy. So, how frequently do you use it personally in people who do not have diabetes and who have Nash?
Okay, sir. In people who don't have diabetes and have NASH, I usually give vitamin E twice daily only. I don't touch metformin because metformin per se, I didn't find any benefit in reduction of NASH because NASH we don't assess by liver biopsy or MR elastography. We usually, our patients from endocrine person, they are looking at grade 1, grade 2 fat liver in ultrasound or SGOT, SGPT only. For SGOT, SGPT to come down, invariably vitamin E is much more effective. But when NASH with pre-diabetes come, when NASH with HbA1c 5.7 or above, I put a combination of metformin with PIO with a vitamin E and send the patient out. But pure NASH with less than 5.7, I always give vitamin E only to the patient unless the patient is having PCOD.
Yeah. So if your patient is pre-diabetic and has NAFLD, then pioglitazone will be the drug of choice. So use it without any fear. You can use it confidently. And you spoke about polycystic ovary syndrome also. So
Yes, sir.
usually we use metformin. Supposing the patient is resistant to metformin, she is not menstruating, she is not ovulating, even after taking metformin. Is there a role for pioglitazone there?
Oh, sir, you know that so many studies have shown that PIO is thought to be 5 to 7 times more effective insulin sensitizer in PCOD patients compared to metformin. And combination of PIO with PCNA also recently have shown PIO with metformin is thought to be much more effective, except in people who go for consumption. When you go for consumption, PIO is relatively contraindicated because it's a category C drug. When you go for consumption, it's metformin. Other than that, if the patient wants a normal ovulatory cycle without consumption, PIO with metformin is always superior to metformin per se, even in lean PCOD patients. So from my
Pio will
perspective,
be, yeah, Pio will be preferred actually, though it is off-label. You just have to make sure that the patient is not planning pregnancy or she is on adequate contraception if she is married, if she is sexually active. Uh, there is a question, a clinical case shared by Mahbub Ali Sahab. Uh, Mr. Ali describes a situation of diabetes remission. He has been taking diabetes medicine earlier, but he has been off medication now for 4 months. The fasting is 79, the postprandial is 116. All other test results are normal. So, two questions for you. When we say all other test results, which are the ones that we must assess, to be sure that we are on the safe side? And secondly, is remission a possibility? What should Ali Sahab do later on
okay.
in
So
future?
from my perspective, I'll ask this just with Sanjay Kanta only. But from my perspective, what's the definition of remission? What's the definition of cure? AD has recommended that a newly diagnosed or existing diabetic patient of all the drugs where HbA1c is less than 5.7 for 1 year is remission. But HbA1c is less than 5.7 for 5 years at least is the definition of cure. So you are having HbA1c normal for 4 months. That cannot be in the condition of remission or cure. It can be a transient normalization of blood sugar. And your transient, how can you have a remission of diabetes? Physical activity, lifestyle, dietary intervention, and bariatric surgery. So physical active lifestyle cannot have a persistent remission. It is your invariably dietary intervention. Newcastle study, ELCC diet, or DMJ study, 15 kilogram weight loss by a fluid-based diet, that can also cause remission. And bariatric surgery invariably causes remission in 50%. But it ultimately depends upon the duration of diabetes, your obesity status, your beta cell reserve capacity, basal C peptide, and the anti-GAT65 antibody persisting in you. So as of now, you can't tell you are in remission, but good, whatever your lifestyle has worked for you, but follow up with HbA1c every 3 monthly and look after 1 year, if your HbA1c is 5.7, it is remission, but after 5 years less than 5.7, it is cure. But a person with pre-existing diabetes, to maintain this is very, very unlikely with lifestyle alone, without a strict dietary intervention or barrier surgery. That's from my perspective. I love Sanjay Kalras.
Any other complications that we must rule out? Supposing some person with long standing diabetes feels very happy that his or her glucose levels are coming down. Usually it's a good thing. Patient might be going to into remission, but sometimes can it be a red flag? Can it tell us
Yeah,
about the
CRF.
existence of any medical or any endocrine disease?
Yeah, it can be a marker of CRF. It can be a marker of hypothyroidism per se, a celiac disease, or an adrenal insufficiency sitting in the patient. Everything can cause a transient remission-like picture.
Yeah. So, Ali Sahab, just make sure that your kidney and liver tests are normal. Make sure that you don't have celiac disease. That will be highly unlikely at your age. But are you eating well? We hope you're not having diarrhea. We hope you're not having loose stools or pain abdomen frequently, and you're not losing a lot of weight. And also make sure that your thyroid and adrenal are normal. One last question, if you allow us to take, Dr. Matthew.
Yes, sir. Yes,
Uh,
sir.
we know that the COVID pandemic is going on, and many times we are not able to reach out to our patients regularly. Our patients are not able to reach out to us. In such a situation, what kind of monotherapy, what kind of dual therapy, what kind of triple therapy are you most comfortable using in your patients?
Okay. I
You
will
don't
use a
know whether the
scenario.
patient will be able to come back to you for the next 3 or 6 months.
Okay. I will correct a scenario where I put a metformin with gliptin with a pioglitazone. Maybe I will not use as SGA2 inhibitor, especially in an elderly patient who is not able to visit you. Okay, some studies have shown that SGA2 inhibitor is safe, but I will always prefer a metformin gliptin with a pioglitazone because no hypo, it's a glucose-dependent insulin secretion, no dose adjustment required in any infection per se. So I will prefer these three. I will not prefer an SGA2 if the patient doesn't, because SGA2 should be withdrawn in patient with acute severe illness or any intervention procedure, any patient with severe illness also. So from my point, metformin, gliptin with a pioglitazone per se, sulfonylurea no, SGA2 inhibitor also no, especially in the elderly.
So, thank you so much, Dr. Matthew. We began with this parable of the lamp, and you've certainly lit the lamp for us. You've been able to explain to us how easy it is to use pioglitazone in a pragmatic manner. There is another parable, and that is the parable of the mustard seed. It's so small to begin with, but when it grows up, the mustard tree becomes so big that it is able to give shelter to so many living beings, apart from giving its fruit to us. I think that is the beauty of pioglitazone. If you use it properly in a pragmatic manner, of course, it will give you glycemic control. That is what it is meant for. But it will give you many pleiotropic benefits as well. And it will support not only glycemic homeostasis, but also, for example, liver health, cardiac health. It will help in tolerability, in safety, in economic tolerability. And the key word which Dr. Matthew used again and again was sustainability, durability. That is what it brings to the diabetes care table. With this, Dr. Matthew, I'd like to thank you once again for joining us. And we
Thank
wish you best wishes for your career, both in Sharjah and in India.
thank you
Thanks
so
once
much.
again from all of us who've logged in today.
Yeah,
Thank you and
thank
Jai
you
Hind.
and being with you also. Thank you so much.
Thanks.